5 minutes after 8. As you can see, before that, I have uploaded 2 presentations, one on IBD, one on IBS. Because when I looked into the syllabus, there is a title, different title here. There's pathophysiology of irritable bowel diseases, CD and UC. Is there anything wrong with this topic? Is CD, UC part of irritable bowel? No.
No,
right?
but it is separate.
It's inflammatory. So it's probably, I think it was even last year that we had the same issue. It should be, here the title is fine, but this is inflammatory bowel disease. Inflammatory and irritable, they are 2 separate things. I had to call, I talked to Dr. Bobo. I asked him, what are you teaching? He said, we teach both IBD and IBS. They have covered it, I believe, already? Okay. So Dr. Bobo did IBD, Dr. Estes did IBS. Okay. But in our syllabus for 649, I didn't see anything on IBS. So I still had the PowerPoint put up there, but you're not required to look at it because there are 5 lectures in this. Remember in the previous exam, I didn't know that either. When we break up for the spring break, we took away 2 classes. So we only had 3 classes, and we still got 45 questions in the integrated exam. So we have to fill in. So each lecture, we gave 15 questions per lecture. But in this case, there are 5. I think that was the only exception here, because 1 week, we lost 1 week for the spring break. So normally these are 5 lectures, 45 points. So you divide that for 45 questions, sorry, divided by 5 is equal to 9 questions per class. So I'm going to cover the CD, UC, drugs, medicinal chemistry part of it. And I'm not going to talk about the IBS, chemistry of IBS drugs. Because some of them are already covered in constipation, diarrhea, but I'm not going to, because there are only 9 questions right now.
So it's not going to be on the exam?
No, not from that.
Right.
IBS, chemistry of drugs on IBS will not be on the exam. So I have 9 questions for this lecture. And I have, there is 1 more, pathophysiology of hepatitis and cirrhosis of liver. That's another 9 questions. So I will have 18 questions, and Dr. Papian will have the rest. So total, it will be 45. 45 questions, 90 points. Remember that. That's what tricked you earlier. It's not equal between this course and the 639. 639 weighs more than 649. It is 110 points for 639, and it's 90 points for 649. So your percentage, what you get is that's what it says, but the raw points may be less. Okay? So I think I clarified that. I said, I asked Daniel to distribute that clarification. I think you all know now how. We should have told you earlier what is the weightage of 639 and 649. When you took the integrated exam, it had 2 courses, right? So that's how you have to go by, and your grades, what you saw in the exam soon after the exam is for the total for 2 courses, 639 and 649. Together, 200 points. 110 goes to 639, 90 goes to 649. You with me? No?
But usually we count out, for me, I usually count my mistakes by course different, separate from courses. But the grade,
A 32-year-old. It's a typical pain, diarrhea, and sometimes bloody stool, and it is weight loss also accompanied by because of the excessive diarrhea. So these people, patients will have the very similar symptoms, but there are subtle differences. So as a pharmacist, you should be able to classify or categorize whether it is UC or CD. So by reading this case, what you all think? Is it a case of CD or UC?
We have a,
I'm sorry. You said something?
I said we haven't read the case yet.
Oh, you haven't read the case? Oh my God, I'm so sorry. Yesterday, I totally forgot in the morning to upload this. Then evening, I remembered. Let's do it. We'll come back and do the solve this case.
Okay.
Okay? Now, going straight into the learning objectives, there are 3 recognized commonly used inflammatory bowel disease drugs on the basis of their chemical classification to which they belong. Evaluate the MOA for each group of IBDs drugs and based on their chemical modification. Modify the chemical groups, remove it, add it, its function changes. So that you should know in this class. Then predict therapeutic applications of IBD drugs based on knowledge of chemical and pharmacological classification. Here you combine today's lecture knowledge from today's and also from the previous, the pharmacology, pathophysiology part of UC and CD. Here is the characteristic, and we call them as triads, classic triad of clinical symptoms. For UC will be chronic diarrhea, which is common, rectal bleeding, I have highlighted it in red, and abdominal pain. Then if you look into the CD case, CD also has a classic triads. Here, abdominal pain, diarrhea, and weight loss. So what I did for comparison purpose, compare and contrast. See, the CD will have weight loss in red, whereas in UC, rectal bleeding is in red. CD, you may not see the bleeding. Why is that? It's pathophysiology. Remember, CD can be inflammation anywhere in the gut, starting from almost at the distal end of the stomach all the way to the top. Whereas UC is, as the name indicates, a colitis. It is mostly restricted to the large intestine, colon. So, if there is a bleeding, there is a chance your red blood cells will be out, will be excreted as they are. Whereas in CD, because if it is somewhere in the early part of the intestine, they will be digested. The red blood cells will not be red anymore because they undergo lysis, they will be digested, and hemoglobin will not go in as intact red molecule. So RBCs will not be intact. Therefore, you don't see rectal bleeding in the diarrhea of a patient suffering from CD. whereas in UC, it is characteristic. If you see the rectal bleeding or bloody stool, that indicates probably, it is not a definitive thing, probably this patient may be suffering from UC. You still have to do other diagnostic tests to confirm it. Weight loss, even in this patient, you saw some weight loss, so we will come back to that. There will be weight loss, both in CD and UC, but which one overweighs what, we will come back, take up the case. And I think I looked into Dr. Kaufman's note. He has touched on pharmacology, pathophysiology, the point by point, and I think on top of it you have Dr. Bobo covered. So I'm not going into back into the pathophysiology of pharmacology. However, I have this slide, the cellular nature of this disease is important. So they talked about natural killer cells, the antigen presenting cells, etc., etc. Do you know their localization? That's what I thought. Let me put that in here. So we'll go into next slide. Shows you. Always a clinical presentation. How a patient comes with abdominal pain, abdominal diarrhea, weight loss, etc. And it is you are the physician to find out what it is. Unlike you see, defining the severity of CD is even more difficult. So pathogenesis, infiltration of inflammatory T cells and B lymphocytes, macrophages, and plasma cells is characteristic of this disease at the cellular level. That's what it shows in this slide. I took it from your Goodman-Gilman. So there are interactions among bacterial antigens in the intestinal lumen and our immune cells in the intestinal wall. That's what causing the inflammation. So the name is inflammatory bowel disease. Infiltration of either the chemical from bacteria or these macrophages from the lumen into the from the parietal cells will cause the dendritic cell activation. That is the first step. Dendritic cells, the activation will release some of the mediators. These mediators are not prostaglandins. They are a different class of pro-inflammatory mediators called cytokines. There are several cytokines, of which there is an interleukin 12 and interleukin 18 are the pro-inflammatory cytokines. That is the root cause for the development of this inflammation. When they are produced, these interleukins, they are collectively called cytokines. Cytokines are a collective name, but if you go into individual cytokines, they have names like interleukin 1 through 12 and 1 through 18, like that. Now, these interleukins will activate downstream cells like the Th0 cells. These are T lymphocyte cells, class called H0 cells, and these cells, the T lymphocytes, in turn produce several other interleukins. So it is more like a cascading effect. So the important ones here are IFN alpha, IFN gamma, interleukin 12, interleukin 4, TGF beta, TGF beta, IL-6, etc. See, these interleukins here, they have specific activity. If it is IL-6, it will activate another T lymphocyte downstream. They are called H17 cells. If it is TGF-beta alone, it will activate another class of T cells called regular T cells. And if it is IL-4, it will activate another class of T cells called H2 cells. And if it is IFN gamma, IL-12, they specifically activate another class called Th1 cells. Th1 cell activation will cause more production of IFN alpha and gamma, which will activate the macrophages. So the macrophages increase in these patients. And macrophage activation will cause the subsequent production of pro-inflammatory factors. And in CD, specifically, Th1 cell activation occurs. Whereas in case of UC, Th2 cell activation occurs. Okay, so that is a cellular differentiation. So when the blood cells are tested for confirmation, UC or CD, you can confirm it if there is Th1 cell upregulation of production is increased, it could be CD. If it is Th2 cell upregulation, then you can say it is probably UC. Again, it is a cellular, at the cellular level, you can differentiate what happens in CD, what happens in UC. Now we will go into the drugs which block the production of particular the inflammatory, pro-inflammatory mediators. The drugs which are talked about in pharmacology are the aminosalicylates, means corticosteroids, immune modulators, biological response modulators, antibiotics. Where do they act? So what if mesalamines are active? How do they bring down the inflammation? That is again going back to this modified slide. The 5-ASA mesalamines act at this level. They inhibit the production of IL-12, IL-18 at the initial stage of the production from dendritic cells. The initial activation, initial production of these pro-inflammatory interleukins are blocked by the mesalamines. Remember corticosteroids. Corticosteroids are even further up in the upstream. They will inhibit this dendritic cell activation. So if you hit it with corticosteroids, it will block further events in this signal mechanism. So it will shut down the IL-12, IL-18 production. Therefore, you won't see any further downstream activity or activation of cells. Then you will be able to block. That's why corticosteroids and mesalamines can be used in both to control UC and CD, because they block the initial events at the upstream level. Then what about the anti-TNF alpha? Here it is further downstream, and the mesalamines can also be used. That's why you can use them as a maintenance therapy at that level. Once you get the remission with corticosteroids, if they block the initial events, then you maintain the patient with the mesalamines. That will stop production of this TNF alpha, TNF gamma. Therefore, you will get relief, specifically in case of CD. What about the other drugs? There's azathioprine acid and immune modulators, they all work at this level, but they are not at the upstream level. So they are specific, therefore you have to be, by that time, you should be able to diagnose whether it is UC, whether it is CD, then you can use these, immune modulators or the nucleotide analogs to control the cell proliferation or production of these pro-inflammatory cells. And you know better than myself, here the table, what controls the mesalamine will be, you will be able to use where, and where the antibiotics, and the corticosteroids, and that's made given in here as maintenance therapy or active disease, so you can compare your notes. Excuse me. That leads us to the second SLO, my mechanism of action of these IBD drugs. Mesalamine is the active drug, but it is better to give a prodrug instead of giving the active drug initially. If you give a prodrug, then the mesalamine can be produced at the target site, therefore mesalamine can act right there to block the production of IFN gamma and IL-2 IL-12 as you saw earlier. So what are those prodrugs? And please note that you don't get any relief by inhibiting the COX activity. There is no direct effect COX activity because it is further down. So here our target should be inhibition of the cytokines. If you inhibit the cytokine production, then you will get the relief. That's what the corticosteroids do. But when you hit it with corticosteroids, remember what happens. It also blocks the phospholipase A2 by increasing the production of a phospholipase A2 inhibitor. That way, it will block the arachidonic acid production. And further down, prostaglandins, thromboxane production, leukotrienes as well. Excuse me. But if you hit it with a COX specific inhibitor, it actually exacerbates the characteristics of UCD. We don't know why. Okay? But these drugs, the mesalamines in general, we know they inhibit these three pathways. They inhibit production of IL-12 and TNF-alpha. That's very important. Then they also inhibit lipoxygenase pathway. That is further downstream. So if they inhibit the IL-12 and TNF-alpha, then downstream events are automatically controlled. Therefore, you get inhibition of lipoxygenase as well. And they also inhibit NF-kappa B, which is a transcription factor, as you need to bring your biochem back into this, the molecular biology. So NF-kappa B is a transcription factor. We call it factor elements which bind to the DNA, thereby inhibiting the pro-inflammatory production of these cytokines. Remember, so cytokines, they're a class of inflammatory agents which are protein in nature. They are peptides, small peptide proteins. That's why transcription factor inhibitor, NF-kappa B, by inhibiting the transcription factor, you can inhibit the transcription of production of these cytokines. So there are multiple places where these mesalamines can block. Therefore, they are effective in treating the patients for long time duration. Remember, you cannot keep the patient with corticosteroids for long. So that's why probably you already know therapeutics, they say get the remission using the corticosteroids corticosteroid, and you taper off the corticosteroid, switch to mesalamine as a maintenance therapy. Let's see the individual drugs. So which are the molecules or which are the drugs that contain the mesalamine? The 5-ASA is 5-amino salicylic acid. It's also called salicylate. Remember, salicylic acid ionizes to give you salicylate. It's a conjugate ion of salicylic acid. But it is not a COX inhibitor. The first line of therapy used in mild to moderate active CD and UC are these aminosalicylate containing drugs such as sulfasalazine, olsalazine, and valsalazine. What does sulfasalazine contain? Here is the chemical structure of sulfasalazine. Sulfasalazine, olsalazide, or valsalazide, if you take any of these, they have things in common. The diazo bonds, that's in red. These are the characteristics of these drugs, of this class of drugs, which make them unique to treat these conditions. The functional group, diazenyl and double bond N, in which R and R dash can be either aryl or alkyl. Aryl is, as you know, it's a benzene case. Aryl, alkyl side chain. If you look into sulfasalazine, there are two aromatic rings, and both of them are connected with the diazo bond. Sulfasalazine, therefore, it is stable. We don't have the enzymes to break this diazo bonds. And what happens is it stays in the gut, it won't get absorbed, and when it goes to the intestine, small intestine, where the microbes are harboring in the patient's blood, patient's gut, microbes metabolize. They have the enzyme to break this up. When they break open, you get two molecules. One is the active drug mesalamine. The other one is another molecule, sulfapyridine, which is nothing to do with, it doesn't have any beneficial effect, rather it has some side effects. That's why sulfasalazine induces side effect through generation of this sulfapyridine component, which is not useful for the patient. Only useful portion is the ASA or the mesalamine portion. So this is unwanted side effect. So what if we get rid of the sulfapyridine? Make sulfasalazine without the sulfapyridine. That's why they tried putting another mesalamine ASA, connect them with the diazo bond. That resulted in the production of olsalazine. So olsalazine has two molecules of ASA connected together through this diazo bond. It looks like sulfasalazine, but when the bacteria works and acts on this, you get two molecules of ASA, which is good. Both of them are beneficial. So you, from one molecule of olsalazine, you get two molecules of the ASA that will help reduce. So there is no sulfapyridine portion coming in, so it will minimize the side effects of sulfasalazine. So that's how they evolved. The sulfasalazine, by the way, is the generation, first generation drug in this class, and modification, removal of sulfapyridine resulted in production of olsalazine, which is the second generation, and another second generation drug is valsalazide. In valsalazide, they thought increasing, instead of increasing the ASA 1 to 2, keep this 1-to-1 ratio. It's just like sulfasalazine. When the bacteria breaks it down, you get 1 molecule of sulfur the ASA. Plus, they put another inert molecule which caused the biosalazide generation. That is the second generation without increasing the ASA concentration. You just kept 1-to-1 ratio, just like sulfasalazine, but there is no sulfapyridine related side effects. So those are the two second generation drugs. So sulfasalazine is a prodrug. Osalazine, valsalazide, all of them are prodrugs because they have to undergo first round of metabolism through the colonic bacteria to give you the active drug 5-ASA.
Can you repeat that one?
Yeah. Is whether you take first generation or second generation sulfasalazines, both have to undergo metabolism. When sulfasalazine first generation undergoes metabolism by colonic bacteria, it produces ASA plus a sulfapyridine, which is toxic, which causes the side effect. To get rid of this sulfapyridine, second generation sulfasalazines are modified, incorporating another molecule of ASA, which causes the production of volsalazine, or adding an inert molecule such as in valsalazide, which is again, it is aryl side chain, but no side effect. That will give you molecule safer without the side effect of sulfasalazine. Where do they put, as I mentioned earlier, all these first generation, second generation sulfasalazines, they inhibit IL-12 and TNF-alpha production. They also inhibit lipoxygenase pathway. They inhibit NF-kappa B, the transcription of the production of cytokines if they are inflammatory mediators. Adverse effects of sulfapyridine is a molecule which is devoid of any therapeutic effects. To overcome this, second generation ASA were developed. The second generation ASAs are osalazide and valsalazide.
Those don't really have that many adverse effects because they don't have the.
They don't have the sulfapyridine. And it's shown in this slide how the metabolism, the activation process, because these are all prodrugs, they require activation. That is what is shown in this slide. There was a typo. It is valsalazide. It said valsalazide, something the L was missing. I didn't notice it. So make that change. Write it valsalazide in that slide. So the net outcome is production of the 5-ASA is improved in the second generation. And the sulfapyridine effect was erased. Now, among the second generation, there are two kinds of second generation ASAs. One is the mesalamine products, just like osalazide or valsalazide, which we already talked. There is another subtype of this second generation, which are coated. They can be coated to delay the release of mesalamine. So they will wait until it gets into the smaller whereas the pH sensitive coating release was done in other classes of second generation such as Ascol, Lilarda, Mazaran. These are all pH sensitive release coating is done. So remember, intestine, when the drugs move from stomach to intestine, the pH changes from acidic to neutral. So the pH sensitive release coating will help when it goes to the neutral pH. The mesalamine is released, the coating is gone, and mesalamine will be released. So these are the variations of the second generation. They can be just the substitution of the two sulfapyridine, or on top of substitution, they will have coating. Some coatings are pH sensitive. That's how I summarize. Here you can see if it is sulfasalazine, it won't be activated until it goes to colon. As we talked about, colonic bacteria will cause this sulfasalazine to metabolize into ASA and sulfapyridine. If it is oxalazine, it also waits until colon reaches colon. That's when it is degraded or metabolized by bacteria into 2 molecules of ASA, and that's how it gives you, provides relief. If it is pH sensitive coating, they can be either released at this earlier time when it enters the ileum, and colon it can be released. If it is delayed coating like Contessa, it can be released anywhere from early intestine to all the way to the colon. So it can be released anywhere. It is a broad spectrum. So Contessa probably gives you good relief because it gets released early on throughout the length of the intestine. Therapeutic uses, I don't want to step into. My colleagues, they are better qualified. So I just, if there is any mistake, I'll just pardon me, take it out. I'm not qualified to give you the dosage. Yeah. Corticosteroids. As I mentioned in early on, remember corticosteroids, it will stop the production of the inflammation early on, that is like at the dendritic cell level. So if it is upstream, upstream inhibition, then forget about all these downstream production of all the cytokines. That's how corticosteroids steroids give you remission, and then you hit it with, of course you cannot keep the patient for longer time with corticosteroids. So once you get the remission, then you can switch to the mesalamines. Corticosteroids can do, they inhibit the IL-12, IL-18 production. Also they can inhibit the production of the prostaglandins, thromboxanes, leukotrienes, which are downstream pro-inflammatory molecules. So that is why you get a total shutdown of these pro-inflammatory mechanisms. Topical steroids, these are in the form of enemas, foam, suppositories, are beneficial for treating distal colitis in case of UC. There is a modified prednisone, modified corticosteroid, which I would like to talk to you. It is called budesonide entopart. What is the difference between prednisone and budesonide chemically? Here it is. Here is the prednisone. In budesonide, you added a butyraldehyde moiety preventing the premature reactivity of the prednisone, and this butyraldehyde protects the OH group, thereby it stays longer, and you can achieve the therapeutic by lower doses of the corticosteroid. That's the chemical modification. Now let's talk about some immunomodulators. Among immunomodulators, these are the nucleotide analogs, 6-mercaptopurine. If you treat patient with azathioprine, it ultimately gets metabolized to 6-mercaptopurine. Okay? So in this case, 6-mercaptopurine is the active drug, whereas azathioprine is a prodrug. It requires modifications or metabolism. They are the commonly used immunomodulators. Of course, here it shows the pathway. I will show you in the next slide. It inhibits purine nucleotide synthesis and cell proliferation. So by inhibiting the purine nucleotide biosynthesis using this 6-mercaptopurine, you can inhibit the DNA transcription, not replication, DNA transcription into the cytokines. Azathioprine may be used as steroid-sparing agent in patients that are steroid dependent. So that you can alleviate the steroid dependence by using azathioprine. However, if the patient is pregnant, can you use azathioprine? No, you cannot. Okay, here is the pathway for azathioprine. Azathioprine, when you give it to patient, it becomes non-enzymatically converted to 6-mercaptopurine. That's important. No enzymes are involved. Azathioprine gets converted to 6-mercaptopurine. That is the active drug. It competes with the purine nucleotide biosynthesis or the DNA transcription. 6-mercaptopurine is metabolized by several different enzymes. Here is you don't need to remember this. The xanthine oxidase. Remember, xanthine oxidase is a purine degrading enzyme, and it converts into 6-thiouric acid. Remember the uric acid production from purines in your biochar. So that's the major pathway how 6-mercaptopurine can be deactivated.
You said one of them doesn't use enzymes?
Yeah, the first active azathioprine conversion to 6-mercaptopurine is non-enzymatic. As such, azathioprine doesn't have any therapeutic value because it doesn't compete with the purine purines. So it has to be converted to 6-mercaptopurine. Just ignore this slide. You don't need to look. There is not much to remember. These are all methylations. Remember, the nucleotides often get methylated, and the methylation will make it look like different compound. So it won't be able to be incorporated into a newer RNA molecule. It doesn't look like purine, but it cheats the enzymes in the biosynthesis. They think, oh, I'm putting the purine molecule, but it is not purine. So the extension or the synthesis transcription process will be inhibited. That's how they block the production of IL cytokines, which are proteins or peptides. Adverse effects, of course, they will cause the nausea, pancreatitis, diarrhea, etc. The patient is already having diarrhea in some cases. It may worsen the patient's Other agents as alternate for the appearance are methotrexate. Methotrexate is a folate antagonist. Remember, methotrexate inhibits an enzyme which is important for making the tetrahydrofolate in the system. So it is not a direct inhibition of the adenylate synthesis, the purine synthesis, but it is, pyrimidine synthesis. Remember thymine synthesis? Thymine synthase is the enzyme, main enzyme, whereas the tetrahydrofolate produces the tetrahydrofolate by reducing the dihydrofolate to tetrahydrofolate. So that methotrexate is the inhibitor of that enzyme. So it's an indirect way to minimize the NSAID. Methotrexate has also side effects. Alopecia, any rapidly growing cells will be affected because it inhibits the thymidine synthesis by inhibiting the replenishing or regeneration of tetrahydrofolate. Other agents, cyclosporin, is a calcineurin inhibitor, which inhibits T-cell mediated responses, has an advantage over 6-mercaptopurine or azathioprine, and used to manage in patients with severe steroid refractory UC. If the steroid doesn't give any relief for UC, then you can alternate the cyclosporin. There are biological modulators. I saw the examples in Dr. Bobchan's notes. One of them is infliximab. These are protein therapeutics. When you start with the protein therapeutics, remember you have to either infuse it into the blood. Why? That requires hospitalization of the patient. Therefore, to drive up the cost, infliximab or any other protein and therapeutics, you cannot just give it orally. Why you cannot give it orally? Why you cannot give these antibodies? These are, by the way, antibodies. They inhibit, they bind to the cytokines, and therefore they will nullify the cytokine effect. But why you cannot give it orally? You just can make a tablet and you give it. Why not?
Acidity.
Who said that? Yeah, what is it?
Acidity.
Acidity. What happens to a protein when it is put in an acidic medium like stomach?
Neutralizing.
It will denature. Remember, proteins get denatured by acidic pH. So when it gets denatured, the protein's purpose is gone. Therefore, you have to infuse that into the blood through all the, I don't remember all the hospitalization is required, so you have to infuse it through a fluid when they give it to you. That will, and the antibodies are expensive. So it is a too expensive therapy. So you will go to this route when nothing is giving the patient any benefit. Then only you probably, if the patient has that kind of insurance or money, then you can go for this antibody treatment. That only the immunologic mediated responses, as I said, because it's an antibody, it will bind to the antigens of the cytokines we talked about. Then it will nullify the antigens activity. That is why it is immunologic mediator responses. Antibiotics, the metronidazole is one of them you can use if the root cause, the causative factor, all these happen because of a pylori infection. Then you can use metronidazole in such patients that will eradicate the bacteria, thereby eradicating all the subsequent signals which cause the activation of the immune cells. It's a metallic taste and also it causes peripheral neuropathy. This I don't think is relevant here. Can I took it off? What do you expect in the exam from this part of the talk? These three are learning outcomes, are the ones which I keep for writing my questions. Mainly evaluate the MOA for ASAs, first generation, second generation. Know that in chemical modifications, that is important. Yes. Any questions?
No.
What about the case study? You want to quickly review the case study? See, I'm sure you know better than me because you already have 639. Yeah. So, what is, based on the case, what is your thought? Is it UC or CE? It is UC because rectal bleeding. You can detect the red blood cells in the excretion, so that's got to be UC. But however, if you go by the weight loss, see that patient also lost weight. So it becomes tricky. So you need to run further tests to narrow down. Then to explain how the antigen triggers the pro-inflammatory responses, these antigens activate the dendritic cells. That will increase the IL-12 over IL-18 production. That is the root cause of subsequent production of the inflammatory responses. What cell types mediate these inflammatory responses? If it is UC in the, you mentioned, because there was rectal bleeding detectable, what cell type would you think is going to be increased in this patient? TH1, TH2, remember it is the TH2 cells. What type of cells are activated in UC? Again, it's written there. TH2, what type of cells are activated in CD? TH1. Okay. Are there any other questions? Or
You said you had 9 questions coming?
that from this lecture. That is my calculation. Again, the final the call will be the coordinator, Dr. Mo. It usually go by divide the number of questions divided by the number of lectures. That's what it is. Okay, there are no other questions.